Welcome to Sleepy Nursing, the podcast where we break down nursing school stress into something you can actually fall asleep to. I'm Nick, for some of you, Mr. Forney, and I teach nursing students how to think critically, survive the chaos, and still get some rest. Whether you're cramming for exams or just need a calm voice with a stethoscope, you're in the right place. Today's episode will cover patients with urinary and kidney issues. This section is packed with key pathophysiology, signs and symptoms, diagnostics, treatments, and nursing care strategies. By the end of this episode, you should be able to recognize common urinary conditions, identify patient symptoms, and apply appropriate nursing interventions. We're going to start with cystitis and urethritis. Cystitis is an inflammation of the bladder, most commonly caused by E. coli. Cystitis, think cyst. Where else have you heard cyst before? In my previous episode, we talked about the gallbladder, which was cholecyst, cholecystectomy, cholecystitis, that sort of thing. With the urinary bladder, cyst actually goes back to Greek. I looked it up recently. It refers to a fluid-filled pouch or sac. So in this case, cyst alone is talking about the urinary bladder. In women, especially older adults, incomplete bladder emptying can lead to urinary stasis, which makes a perfect environment for bacterial growth. Symptoms can include painful urination, urgency, low back pain, and sometimes confusion in the elderly. If you have an older adult who's confused and you don't see any other symptoms, it's always worth considering, could this be a UTI? Diagnostics we'll use for this are probably things you're familiar with. They can include a urinalysis and a urine culture. Treatment typically involves antibiotics, things like Bactrim, and analgesics, which help reduce pain and discomfort, like Pyridium. An interesting thing to consider about Pyridium is that will turn your urine orange. So if you're starting a patient on Pyridium, that would be an important thing to include in your education, so they won't be surprised or caught off guard or call you in very alarmed. My urine has turned orange. What's happened? Other things we can do to be helpful. Hydration is going to be helpful. The more fluid we can drink in, the more we can flush out the bacteria and hopefully help this patient feel better. Comfort measures can include those sitz baths too that can provide some localized comfort. Now for urethritis, again we have the itis, which we know always refers to inflammation or infection. Inflammation typically, but can be very commonly caused by infection. This is now in the urethra. So think burning, itching, and discharge. Causes can range from sexually transmitted infections to chemical irritants to an infection that's come down here too. Treatment is the same as you would expect with cystitis. We will manage, depending if it's a STI, that may be a treatment for that specific STI. For a chemical irritant, it may just be flushing it out. Think if you've ever had soap in your urethra, it is very uncomfortable, and the only way to resolve it is to flush it out. And if it's a bacterial origin urethritis, obviously we'll go into antibiotics. The Pyridium will also be helpful here. Pyelonephritis. This is a kidney infection. We're no longer just in the bladder. Our infection, most often in pyelonephritis, has ascended up the ureters and into the kidneys. This often comes from bacteria, think that same E. coli like we experienced before. Symptoms can include fever, and if it's a kidney infection, this will be a vicious fever, and think how central the kidney is to our body. So we'll experience chills as well, nausea, and flank pain. When we get into thinking about flank pain, remember back to your anatomy class where exactly your kidneys are. They are about halfway up your back, right where your rib cage meets your abdomen. kind of tucked right behind the rib cage. So we think flank pain, we think kind of middle back, medial in the middle of the body pain. Diagnostics will include the same urinalysis we experienced before. You could see a KUB x-ray, that's kidney, ureters, and bladder. They just describe what part of the body's they're examining in that x-ray. And you could possibly go so far as to require a CT scan or an MRI. For acute treatment, we will most likely look for antibiotics. Remember, pyelonephritis most commonly comes from bacteria that has ascended from the bladder, so it makes sense that our treatment would be the same for that bacteria, whether it were in the bladder or whether it's made its way up to the kidneys. Fluids will be very important here to help flush any bacteria out of the kidneys. And when we get into the kidney infections, this is where we'll start to look for rest as well. Chronic cases of pyelonephritis may lead to kidney damage. Moving on to glomerulonephritis. Acute glomerulonephritis frequently will follow a strep infection. So a strep throat can then, usually a few weeks later, move down to the kidneys and cause glomerulonephritis, which is, in this case, immune-mediated kidney inflammation. Symptoms can include puffiness, hematuria, hypertension, and smoky urine. So when we think about puffiness, think about how much our kidneys manage the fluid that we hold on to or excrete. And if they're not working right, we're going to accumulate fluid in some of these spaces we don't normally accumulate fluid. Labs will show elevated BUN, that's blood urea nitrogen, and creatinine. So if we see both BUN and creatinine elevated, we're thinking kidney damage. If you see one alone elevated and the other's okay, there are some other causes, but we typically look for BUN and creatinine together elevated to look for kidney injury. For this specifically, because remember this one is immune mediated, we treat with corticosteroids, which simmer down the immune system and bring it back under control so everything will get back to working like it's supposed to. These patients will require fluid and sodium restriction. Remember, water follows salt, so we want to limit the water as well. And antihypertensives as well. Chronic glomerulonephritis can quietly progress to renal failure. All right, we're moving into nephrotic and nephritic syndromes. So with nephritic syndrome, think about the I in nephritic, NEPHRITIC. Think I for inflammation. The main problem with nephritic syndrome is inflamed glomeruli. What's this going to look like? These patients will likely have hematuria, so bloody urine. It may even be so severe or different to be cola or tea colored, think dark brown. You can see mild to moderate proteinuria. You can see hypertension. Despite these glomeruli being inflamed and a little leaky, they're still holding on to more fluid than they normally would. You can see oliguria. Remember, olig means low, so in this case, low urine output, oliguria. Azotemia, that's the increased BUN and creatinine we discussed a few minutes ago. Your urinalysis can show red blood cell casts. What can commonly cause this? A post-streptococcal glomerulonephritis, which we just discussed. Lupus nephritis as well. What do we do about it? Treatment for nephritic syndrome, we need to treat the underlying cause. So if it's from an infection, we need to treat with antibiotics. If it's from that streptococcal glomerulonephritis, obviously we would go for steroids to help manage the immune response. The inflammation we'll experience with nephritic syndrome we'll manage with corticosteroids. Remember, those steroids go in to help mediate the immune system and cool its jets a little bit, if you will. We need to help these patients manage their blood pressure because they're going to be holding on to fluid. And that leads us to our nursing interventions. Will include a fluid restriction, diuretics, I's and O's. This is a patient who it's important to do strict I's and O's. I need to know all the urine that comes out of them and all the fluids that they ingest as well. And we'll do daily weights too. Remember, daily weights are our best way to tell how fluid is either holding or not holding over time. Now, nephrotic syndrome has the O in it, NEPHROTIC. And the best I can do for you to try and connect it, think O for massive protein loss. The protein has an O in it, but it's a little bit of a stretch. I think it's easier if you remember nephritic is for inflammation and nephrotic is the other one. In this case, our main problem is leaky glomeruli. In this case, it's not inflammatory damage. What we'll see is the severe proteinuria, so lots of protein in the urine, hypoalbuminemia, so decreased amounts of albumin. And remember, albumin is one of those things that helps keep fluid inside our vessels. So if we don't have enough albumin, we're likely to be a little leaky and lose fluid into a lot of third spaces, which leads us to our next symptom, severe edema. In these patients, we can see it particularly periorbital, so around the eyes, and the lower extremities. Think the fluid is subject to gravity just like we are, so the fluid is more likely to be drawn down to the lower extremities dependent. We can also see hyperlipidemia, so an increase in cholesterol and lipids. Frothy urine in this case. And our urinalysis clue can be fatty casts. Common causes of nephrotic syndrome can include diabetes and membranous nephropathy. It's a hard one to pronounce, nephropathy. How we treat this, we'll treat it with corticosteroids. If this is autoimmune, we'll include immunosuppressants. We may include ACE inhibitors, statins, diuretics, albumin. We'll provide skin care for the edema and psychosocial support. And just to remember again, nephritic versus nephrotic. Nephritic syndrome has inflammation and you'll experience likely blood in the urine. Nephrotic will have a lot of protein in the urine and more edema. When we think about our nursing focus, we're going to look for our same daily weights, skin care, and monitoring for complications. Hydronephrosis. Hydronephrosis happens when urine backs up into the kidney due to obstruction, causing dilation and damage. I think this is ultimately causing damage to the kidneys, though it's not usually starting in the kidneys. This will happen if there's, for any reason, urine backs up the ureters and pools in the renal pelvis and can't get out. This could be from kidney stones, which can block a ureter or wherever they may get lodged. You could have a congenital blockage. You could have especially in a child or someone whose ureters didn't structure themselves correctly. You could see blood clots clotting in the ureter, depending on what's going on. If we're experiencing one of those glomerulonephritis or the other one, the pyelonephritis, if they're having such an issue that they're bleeding, that blood can clot and get lodged in the ureter and cause these issues. You could see hydronephrosis coming from scarring of tissue if they've previously had work done on their ureters or anything down that urinary traffic. Tumors may cause this. Think about a tumor, wherever it may be pushing, is where we'll see problems. If it's pushing on the ureter and preventing the normal drain of urine, then we can see hydronephrosis. An enlarged prostate can also cause this. If we're holding on to urine, if it backs up enough, it will cause hydronephrosis. Pregnancy can contribute to this, and urinary tract infections as well. This may be asymptomatic. Your patient may not note any specific symptoms, but it could have flank pain as well. The problem with this is while your bladder is stretchy, your bladder can hold, I think it's between 1,200 and up to 1,800 mLs of urine. It can't stretch forever. So if urine keeps accumulating, which remember our kidneys, if they're working pretty much like they should be making a minimum of 30 milliliters of urine per hour. Those kidneys keep pushing out urine. The bladder's full. It backs up the ureters. The kidneys don't stretch. They are really made of these very fine microscopic filters that help manage our fluid and waste products, and they really don't stretch at all. So if the fluid starts filling that renal pelvis, it'll start pushing and damaging the kidneys. If we catch this and are able to manage it, this could resolve without causing chronic issues. But if we don't catch it, it can progress to damaging the kidneys and causing renal failure. Now, if we do catch it, we just need to get the urine out of the way. Maybe if that's from that BPH, we can just drain the bladder and let the urine come out that way. If there's another blockage, we might have to go so far as placing a nephrostomy. That's a tube that goes into the renal pelvis, collects the urine, and sends it outside of the body to a little pouch that you as the nurse will monitor and drain. We may need to go to surgery. It just depends on what the issue is. If the ureter is blocked, we need to unblock it so that the urine can flow and not back up into the kidneys. Renal stenosis is a narrowing of the renal artery. That's the blood flowing into your kidneys. It can lead to hypertension. The interesting thing when you think about renal stenosis, this often lives within the atherosclerosis family of diseases. In this case, whereas coronary artery disease, there are plaques building up in the arteries going to serve your heart muscles. In this one, it's a plaque building up potentially in your renal artery. Where we get into problems is our kidneys do an awful lot to manage our blood pressure. So in this case, if our kidneys are getting a signal that our blood pressure is lower than it actually is because we're not getting as much systemic blood flow to the kidneys will keep trying to adjust our blood pressure up. So we can see greatly increased blood pressure actually. So hypertension is one of our biggest things we think about when we think about renal stenosis. How do we manage it? We can do angioplasty, where we restructure those blood vessels. We can go in and place a stent, where we put a balloon into the artery, inflate it, and it leaves behind this little mesh that holds the artery wider so it can get proper blood flow. All right, kidney stones. You might hear these as kidney stones or renal stones or nephrolithiasis. There's a few terms for the same thing. They're kidney stones. They are solid masses that form in the urinary tract. Very commonly, these come from calcium that's built up. It's not getting washed away, though there are a few other kinds of kidney stones as well. I think it's 80 or 85% in that ballpark of kidney stones are calcium-based. Risk factors. The biggest one is dehydration. If we're not drinking enough fluid, we are not going to flush any of this stuff that may build up inside of our kidneys out, and it can accumulate and turn into a stone. We can also see immobility being a risk factor. Think about the immobilized patient, someone who's laying in a bed all the time. Urine is likely to pool and not drain very effectively in that patient, and that leaves them very prone to stone formation and these minerals building up. Also, think their position is usually laid on their back or a low Fowler's position, where our bodies are made to be upright a lot of the time. Our kidneys, immediately below, inferior to our kidneys, is our ureters, which run basically straight up and down to our bladder, which then needs to drain out with gravity. It's would be hard, though I'm sure you could urinate while doing a handstand. You're not going to get full emptying. Not that our immobilized patients are doing handstands, but just to think about that anatomy and how it contributes in this case. Diet can be a factor as well, and urinary tract infection. What does a kidney stone feel like? I have firsthand experience of this. It feels awful. I had one and I thought I hurt. It was in my middle back towards the kidneys, flank pain. And then I moved around walking outside, and it must have dislodged the kidney stone and made it hurt 10 times worse. And it knocked my legs out from underneath me in the driveway. It's incredibly painful, so intense flank pain. You can see hematuria, blood in the urine, because remember, these stones are sharp and nasty. Look up a picture of them if you can. If I get really fancy, I'll include a picture in this video. And you can see nausea too, especially from that severe pain. How do we diagnose our kidney stones? Most often with imaging and a urinalysis. So when I went to the emergency department, first of all, they were very quick to give me very strong pain medicines. They gave me a Dilaudid without me, I told them my pain, and that's what they went to. They do not underestimate the kidney stone pain. And then they sent me for a x-ray, that same KUB, kidney, ureter, bladder x-ray that we talked about before. What do we do for this? Treatment typically includes fluids. We need to flush this stone out, pain control, like I talked about, and sometimes something called lithotripsy, where they can break up the stone from outside of the body, which is actually really cool. And maybe we'll have to go as far as surgery, though normally fluids, pain control, give it some time. It's terrible if they think it's small enough that it'll pass on its own. They don't want to cut you open. Think about all the complications that come from surgery. They may also provide something to help relax the urinary tract, something like a tamsulosin, like you could see with BPH, just to relax things and hopefully let that stone move on. How do we prevent kidney stones? We want to increase fluids. We may need to manage our urine pH and watch for dietary triggers. People who get kidney stones are more likely to have more kidney stones, and that's where our lifestyle changes may be very helpful. We want to make sure, or we want to at least try to capture the kidney stone. Often we'll have our patients void through it's like a colander, it's a filter basically, that will catch any stones that come through the urine, just so that we can try to identify what kind of stone it is, if it's from calcium or one of the other kinds of kidney stones, which can help drive our dietary changes. Trauma to urinary structures. Kidney trauma can result from blunt or penetrating injuries. Ureters and bladders can be damaged. Think about trauma, anything that can go in and cause injury to the body. If it ends up in the path of the kidneys, ureters, bladder, or urethra, can cause trauma. With all of these, you want to look for hematuria, which could indicate excessive bleeding. And if we're having a lot of bleeding, we can see shock. While we're thinking about that, think about how very vascular our kidneys are. So if we have a kidney trauma, it is more likely to have massive bleeding. If someone has been injured enough to hit the kidneys, remember they're kind of tucked up behind the rib cage, so they have a lot of protection. That suggests a pretty big mechanism of injury. or a penetrating trauma of some sort. Now, if our kidneys are damaged enough to bleed, we don't have to have an injury that actually penetrates through the skin. We could have an aggressive, like a car crash, that causes the kidneys to rupture and bleed. They may not be bleeding out of the body. If the kidneys bleed, they may bleed into the retroperitoneal space, in which case you'll see massive bruising across the back and the flanks. It's very distinctive. So it's something to keep in mind. We're very concerned about massive hemorrhage that can send someone into shock, thereby affecting perfusion throughout the body. Treatment totally depends on how severe the injury is. If it's just a little kidney injury and it's been bruised and bothered, but it's not bleeding and broken, we could just have rest. This may be even bed rest. We don't see bed rest for very many conditions anymore, but kidney injury can be one that can call for bed rest. Or this can go all the way to requiring a nephrectomy, where they completely remove one of the kidneys. Or obviously they can't remove both without adding a new kidney in. But if one of your kidneys is damaged enough and it's bleeding out, they may have to remove it so you don't bleed to death. Bladder trauma often involves rupture, especially if a bladder is full of urine at the time of injury. This can require prompt surgical care. And through all of this, think our kidneys are still hopefully making urine. If our kidneys are not making urine, we have a whole other host of issues we have to deal with. But if our bladder is ruptured, it's going to keep filling and draining urine where it's not supposed to drain urine. These patients may need some kind of diversion for their urinary tract. It could be a ureter diversion, or it could be a nephrostomy like we discussed earlier. And these are considerations we need to take when we think about urinary tract injury. This leads cleanly into urinary cancers. So bladder cancer can happen. It's relatively common as far as cancers go. It is more common in older men and smokers, of course. Some of the materials from smoking can make it out to your urinary tract and eventually cause bladder cancer. In these patients, our most common symptom is hematuria. So if we have bladder cancer, we often will have an ulcerated mass of cancer in our bladders. Remember, cancer is basically the cells of where the cancer originates, in this case the bladder, but they're not growing into normal bladder cells. A normal bladder structure will be shaped like a bladder, and it will fit into the wall of the bladder nicely. These are immature cells who can't quite figure it out. They can kind of call for blood vessels to develop, but they're immature blood vessels, and they tend to be leaky, so we'll see that hematuria. What do we do about bladder cancer? If we catch it early, we may be able to treat it with surgery. If it's a little piece, they might be able to cut it up and patch it up and keep your bladder. If it's too advanced, they might have to cut more out. We can see a BCG therapy, which is a actual virus, as I understand it, that we infuse into the bladder, and we'll have our patients move around and let it dwell in there for 30 or 45 minutes is how I feel like I've seen it before. And it's actually really cool. It targets, because you're able to put it directly into the bladder, it's more localized, so we avoid some of the systemic effects of our traditional chemo, though administration is not necessarily comfortable. Think if your bladder is full for a long time and you're not allowed to void, it's a little awkward. Or we could see traditional chemotherapy for this. Kidney cancer often presents asymptomatically. Think on a normal basis, you don't normally feel your kidneys at all. I don't feel anything in my kidneys right now. And cancer isn't necessarily painful until it gets advanced or it pushes on something that's very sensitive. So early kidney cancer may not be detected until it's progressed, maybe even until it's metastasized out of the kidney, and curing becomes much more challenging. Symptoms of kidney cancer can include weight loss, hematuria, and flank pain once we get to a pain situation. What can we do about kidney cancer? Again, if it's just a little spot, they can cut it out, throw it in the trash can, and send our patients on their business. But it can be as severe as requiring a nephrectomy, which is a major surgery, and may require other adjunct therapies as well. So in renal failure, many of these conditions we've talked about already can cause renal failure. If we see acute renal failure, that's something that can come on suddenly and will hopefully resolve as well if we can get to the underlying cause and stop the damage. In acute renal failure, or ARF, we can see sudden loss of kidney function. This can be from toxins, nephrotoxic drugs especially. If you ever see that in your drug guide, that's what we're talking about. Trauma can cause acute renal failure, or ischemia. What would cause ischemia? This can come from affected perfusion. Maybe someone has gone into shock or had very low blood pressure for too long. Our kidneys are very sensitive to our blood pressure. This is another one of those cases where I kind of think of it as adding insult to injury. You've had a issue in another body part, or you've suffered a major trauma that didn't hit your kidneys, and now the lack of perfusion is causing kidney damage. What will this look like? We're likely to see low urine output. Remember, we want normal kidneys to make at least 30 mLs of urine an hour, every hour, forever. In this case, we might see it dip below that. We can also see electrolyte imbalance, because remember, a lot of our electrolytes are managed through our kidneys as well. Chronic renal failure. If we don't get to the cause of the acute renal failure, it can progress to chronic renal failure, but we can also very commonly see this come from diabetes or hypertension. Think about your kidney failure patients if you've experienced them in a clinical setting. This is a very common course that they've had from that. Again, our kidneys are very sensitive to blood pressure and all of our perfusion. If we get to chronic renal failure, you can see that as CRF or CKD for chronic kidney disease. As far as I know, they mean the exact same thing. I don't know why we have so many acronyms for these things. We stage that, and stage 1 is mild, stage 2 and 3 are getting moderate, stage 4 is pretty severe kidney injury, and then end-stage renal comes after that, and sometimes it's called stage 5, but usually we just call it ESRD, end-stage renal disease, and that requires dialysis most often because our kidneys aren't functioning. What dialysis does is comes and filters our blood and body fluids and replaces the function of the kidneys. We can keep someone alive on dialysis for a long time. Sometimes people will be on dialysis for 10 years. Once you get to end-stage renal, the only thing that can actually cure you and take you off dialysis would be a kidney transplant, which is not always an option for all of our patients, unfortunately. We have several types of dialysis we can do. There is peritoneal dialysis, which is done daily. In this, they have a catheter that goes through the abdominal wall into the peritoneum, hence the name peritoneal dialysis. In peritoneal dialysis, they will infuse a dialysate, which comes and pulls all of the toxins and things that are supposed to be pulled out by our kidneys into this dialysate, and it's then drained. This is typically done every day. These patients can actually do it overnight while they're asleep. They have to think about your patient. Is your patient going to be able to do this every day? You have to teach them how to handle all these supplies in a sterile manner because we're going into our peritoneum. and they have to be consistent and reliable with this. If we screw it up, think how easy it would be to get peritonitis if a bacteria or some kind of pathogen makes its way into the peritoneum through not totally clean practices. That can be devastating for these patients. The other kind of dialysis that we're probably more familiar with because we see more of it is hemodialysis, sometimes abbreviated to HD. This is most typically, I've always seen this done 3 times a week, and this is done typically long-term through a fistula. A fistula is basically it's a technique. We'll take a artery and connect it to a vein, and it makes a fistula. Just like other fistulas we've talked about in some of our cancers and other body systems, this is just a connection between 2 things that aren't normally connected. This time it's on purpose, and it allows us to exchange our blood efficiently in the setting of dialysis. These patients will go in 3 times a week, usually Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, until they get a new kidney. This takes hours and can be very draining for these patients, but it lets them live, which is really cool, obviously. There is some opportunity for a very reliable patient to be able to do this at home, though you most commonly think of this happening at a dialysis clinic. When these patients do come into the hospital, we have to continue their dialysis or else they'll die. Even if they've come in from something else, they can't just stop dialysis. Most major hospitals will have a dialysis unit associated with the hospital, or they may be able to do dialysis at the bedside. These patients will need to be in a special room if that's the case, with the hookups for all the fluids that dialysis requires, but that can be a cool option as well. But if our patient needs dialysis, even if they're in the hospital for something totally unrelated, we have to continue their dialysis. Finally, these patients can get a transplant. A kidney transplant is a major operation. Interestingly, they don't always remove the damaged kidneys. Usually they'll leave the non-functioning kidneys in place unless there's a very compelling reason to remove them, like a trauma or some major infection that they just can't get past. Then they'll place a new kidney from a donor, and these can be from living donors, though they're also often from deceased donors. They'll place it down in the abdomen, actually closer to your pelvis, and then plumb it into the arteries and veins and connect a ureter up to the bladder, and then we don't require dialysis anymore. Now, there's all the downsides of transplant with this. These patients will be on immunosuppressants for the rest of their life, and they are at risk for all the graft versus host kind of concerns that we have with any transplant. But it gets them out of the hospital, it gets them out of the dialysis clinic, which is very cool. That wraps up our episode. Remember the importance of prevention. Hydration, hygiene, and early intervention are huge to prevent kidney injury from becoming kidney damage and getting on that chronic kidney disease spectrum. Urinary conditions can progress quickly. Your role as a nurse is essential in identifying and intervening early. Thanks for listening. Keep taking good care of yourselves and your patients. That's it for today.